So as we said, renal anatomy, and this presentation has 3 parts to it. We've already discussed that. So just to give you an idea, this is the renal system. You see the kidneys here. I'll just find where my pointer. So these are the kidneys here, you see, and these are the ureters. The ureters connect the kidneys to the bladder through this oblique angle which it inserts into the bladder. So this is just an idea of where they are. Now, the kidneys lie between level T12 and L3. T12 is just basically thoracic level 12. And it's referring to the vertebral column here, as you can see, which is the 12th thoracic vertebral column, thoracic level, basically. And thoracic means in the rib, like near the rib cage. So T12 to L3, and L3 means lumbar region. Lumbar meaning like abdomen or just lumbar region. So T12 to L3, kidneys lie between those levels. I think as you've noticed here, the right kidney is a bit lower than the left kidney here. That's because the liver, this huge organ, is buffering the rise of the kidneys. And as you will see in the renal unit, the kidneys in embryology, they rise up. So the rise of the right kidney is buffered by this huge liver. Now, again, so T12 to L3, and it's a bean-shaped organ. You can see some very important relationships here. The kidney is retroperitoneal. And I think you've come across peritoneum. It's like a mesothelial covering of the abdomen. You don't need to worry about it, but just remember it's retroperitoneal, and stomach and duodenum, stomach is here, and duodenum are here. And this is the superior mesenteric artery, a branch of the aorta, and the superior mesenteric vein. And you can see the pancreas here, and obviously the adrenal or suprarenal glands, they're the same thing, are also there. So again, this is the posterior markings of the kidneys. You notice that the ribs are really closely related to the kidneys, the 12th rib and the 11th rib. And you can find the kidneys here clinically. So keeping in mind that relationship of the kidneys with the ribs, I'd like to go through a case study here, which I found. So this is a 70-year-old female who had trauma to her abdomen and thorax. So I believe the ribs have fractured, and the kidneys, because of the closeness to the ribs, have suffered some trauma. So you can see the right kidney right here, and you see that sort of darker covering of the darker like opacity around the kidney, which is not present in the left kidney. That is bleeding around the capsule of the kidney. Okay, and you can see it here. Also in this view, which is a transverse view, you can see the bleeding around the kidney here, but not here. So that's the relationship there with the ribs. Now again, the ribs. Now I'd like to point out that there are some relationships that you need to really think about in terms of the kidney. Cameron will go through this quite nicely. The psoas major muscle is here. The quadratus lumborum muscle is here. Transversus abdominis would be more lateral, and the diaphragm would lie above the kidneys. Again, notice that the right kidney is a bit lower than the left kidney because of the liver here. Okay. Again, the posterior relationship. These 3 muscles are very, very, very important. So please make sure you know them in your exams and so on. Cameron, I think that we had a question.
Yeah, we have a question. Alicid is asking, is there a space between the muscle and the kidneys?
Yes, we're going to cover that right now. Thank you. Just a few more slides, like one more slide. So quadratus lumborum is this muscle. Cameron's going to cover it very nicely shortly. Psoas major and psoas minor are here. Iliacus, which is not related to the kidney, but you will come across it that iliopsoas as it goes and attaches to the lower limb. And transversalis abdominis is here, which comes across and to the front of the kidney, which would be somewhere here. Okay, so these are the coverings that Alice, I think, asked about. So the kidney is covered by 2 layers of fat. The first layer of the fat is the perinephric fat, which is immediately in contact with the kidney, so perinephric fat. The second layer of fat is the paranephric fat. These 2 layers are separated by renal fascia. So perinephric is separated from paranephric by renal fascia. And if you've noticed, again, going back to this case study here, you see that the bleeding is limited to around the kidney. I think the bleeding is in the perinephric fat here, and it is stopped from spreading by the renal fascia. So that's a nice relationship to keep in mind. Going further, now we've discussed the posterior relationships. Now let's go through the anterior relationships. Cameron will show this very nicely in his presentation, but some important things to remember is that pancreas is here, just here. Suprarenal gland obviously sits above the adrenal gland, sits above the kidney. You got some relationships with the duodenum and the colic flexures. I think second years would know that the colic flexure here would lie here, and we'll see them very nicely later on. So in terms of relationships with blood supply, this is a very, very important point. So first of all, let's talk about the arterial supply of the kidney. This is the aorta, abdominal aorta. They also call it the big red. It gives 2 branches off of it, one to the left kidney and one to the right kidney. And the left one is called the left renal artery, and the right one is called the right renal artery. That's all fine, but the inferior vena cava, which supplies the venous drainage to the kidney, the right renal vein, you see, goes straight to the kidneys, but the left renal vein is under the superior mesenteric artery. And if that angle, which is called the superior mesenteric artery, aortic or aorto superior mesenteric artery angle, is less than 42 degrees, you can have entrapment and sort of like strangulation of that vein here. And the vein cannot drain properly into and out through the heart of the vena cava, and you will have engorgement of the veins here. We'll see it here. And this is called nutcracker syndrome. So you see the SMA, that angle is not preserved of 42 degrees. This is the angle. And the renal vein is pushed upon and cannot drain blood properly, which causes varicosities. And we'll see how testicular vein, you get testicular varicosities there also. So one other important relationship is the duodenum here, which Cameron is going to show us. It runs below, sort of more inferior or more below the superior mesenteric artery also. So if that angle is not preserved, along with your veins being engorged and not properly draining, you can also get obstruction of your bowels, and gas and feces can pile up. Now, this is a very complex, not very complex, but it is, you have to go over it yourself. I just want to show the passage of urine because most people confuse this. So I've shown here the passage of urine. I think it will probably help you in your term 3 if you're Med 20. But let's just go over the kidney. Kidney is made up of outer capsule, which is dense, irregular connective tissue, and a cortex. Cortex is always obviously more outside. And you got the medulla here. These white bits are called renal papilla. Anything, I think papilla, as far as I know, is like an anchorage point. So if you refer back to skin histology, papillary dermis is sort of an anchorage point, or like dermal papilla is sort of an anchorage point of the dermis to the epidermis. But yes, and again, the renal cortex, and then you go into the minor calyx and the major calyx, where urine then flows into the renal pelvis and into the ureter. And this is again for your reference. It's quite a helpful diagram. I had troubles with this myself, so it will help you. Now, this slide is very, very, very important. Please study this properly. So this slide just points out several stricture points. So where the ureter becomes narrow, and you can have stones being stuck there, so causing pain, colicky pain. So renal stones can get stuck in these three areas mostly. So you got first of all, you got the ureter-pelvic junction. Remember that we talked about the renal pelvis. So ureteropelvic is ureter and pelvic junction. So around here. So that's the first part where the stone can get stuck. The second one is the pelvic inlet, where you enter the true pelvis. And you're going to see the anatomy next, and also the entrance to the bladder. We already talked about this entrance, which has a weird oblique angle and it's a good thing, because if you don't have that angle, urine can backflow from your bladder into your ureters, and it could cause something called hydronephrosis, which is not good. So I believe that's the end of my part. I'll just give the next part to Cameron to do, and thank you so much.
Okay, thank you, Amir. I will share my screen. And again, can you just keep an eye on the chat, Amir?
Yes.
You're probably better at answering questions than me anyway, so just answer them as you feel necessary. So using the anatomy app, basically what we did was put together 4 main screens, is what they call it. So you can put together structures that you want to see and see how they're related to one another, and basically save it as that, and you can have labels and you can add in annotations, etc. So Amir, can you see my screen just before I start? Yeah.
Yes.
Okay. So what we'll start with is the general anatomy of the kidney. So is it possible for these screens to be shared? So we're trying to figure out the best way to use the anatomy app for everyone to have access to. Amir and I were making these, and we tried to make them accessible to one another, and we haven't yet found a way where you can share them properly.
I can. We can create new ones and share them with everyone, but we need to. We'll figure it out and share it later. But these are quite useful, and we will share them with you.
Yeah. So just starting off with general kidney anatomy. So like Amir mentioned, this just gives you an overall view as to where it's located in the body. So we can see quite obviously down here at the bottom the pelvis, and you can see that the urinary bladder sits nice and centrally there, with the 2 ureters would be exiting at the oblique angles that Amir had mentioned, and coming all the way up, basically running just at the side of those spikes coming out of the vertebrae, or transverse processes for those in second year, running right the way up into the major calyx of the kidneys. And you can see I haven't added the vessels in for this one, but they are in another one, so we'll be able to see the stricture points, etc. But it's really nice to see that without anything else in front of it, that the left one sits quite a good bit higher there than the right one, and you can see how the liver can fit in there, which is what we'll move on to in a second. But just to start with the posterior relations to the kidney, so those things that are sitting behind it, and that's quite important when you come to look at kidney pathology and think about what structures can start to be affected when things start to go wrong in your abdominal cavity. So if we take a look from the back, I've removed the vertebrae from this area. So I've removed all of so I've removed L1 and L2, so the top two lumbar vertebrae, and then T10 and T11 and 12 as well, just to be able to see that the kidneys sit there. So that's the level that they would be sitting at normally. And the way that I like to think about it is that the muscles make a pretty quiet transition out to the side. So P, Q, and then T. So starting most medially, we have psoas major highlighted there. So it basically runs from just in line with the top of the right kidney all the way down and basically attaches onto your femur, which you'll see when you come to the MSK in term 2. A very important muscle for movement of the lower half of the body. And then next, the Q, so quadratus lumborum, that big whacking muscle right there. So you can see that attaches right across the top of your pelvic bone there, giving you nice lumbar support, keeping your back nice and strong in that region where your back basically curves in before the lower half of your body. And then the last one, transversus abdominis. So this muscle starts right at the edge of that transverse process, or the sticky out part of the vertebrae, right there, and then it's attached to the pelvic bone, comes all the way around the front, and basically attaches up here at the top of the bottom of your sternum, so that nice hard bone in the middle of your chest, and then comes all the way down to basically attach to the start of your legs, really, in the midline there. So those are the posterior relations, and it's quite easy to forget about transversus abdominis and the fact that you'd think about it as a muscle that's more prominent in the front. For those in second year, we've just done the abdominal anatomy, but it really is important to remember that it comes all the way around the back and attaches there, you can see. So it is a posterior relation of the kidney. Next, moving on to anterior relations of the kidney. So really looking at the digestive organs, and I've just included the photo that Amir had on the slides there, so you can see where they're overlapping. But I thought it was quite nice to show you that, all of the... What did you say the acronym was for them? Pretty quiet transition out to the PQT, if that helps. Probably doesn't help many people, it's stupid, but anyway. You can see the liver really, as Amir said, buffering the heightening of the kidneys in development. And then if we move around to the back, I've removed the vertebrae, so we can see everything nice and clearly. But you can see there the kidneys sitting nice in that T12 to L2 area, and right in the middle there, so not really in front of the right kidney, as you can see on Amir's diagram in the top right hand, but coming across to cover the front of the left one, the pancreas, right there. So that's it highlighted in green. So that doesn't cover the right kidney, but it does come across to cover the front of the left one there as it goes. And don't worry about the fact that it says posterior pancreas or whatever like that. Just focus on the fact that it's a structure as a whole, as an anterior relation to the kidneys. As well, so the liver covering the top, basically the top arching section of the right hand kidney there as well, and the gallbladder. So that is, if I've got it labeled here, that is that green looking structure there. So that basically hangs below, it's nestled in nicely below the kidney, below the liver, and it just basically hangs in front of the duodenum, or the start of the intestines there, covering the top right hand kidney. So as we said, as Amir said, the stomach, quite an important thing to be thinking about in terms of relations and pathology in the abdomen. The stomach covering quite a lot of the left hand kidney, and then as the stomach moves towards the intestine, we have the duodenum, which is this curved structure here where it comes down and then it starts into the small intestine, really. The stomach covering the left kidney and the duodenum covering the right, as you can see from there. And then obviously the two most obvious structures here being the small intestine and the colon, or the large intestine, whatever you like to call it. They're really interchangeable, but I wouldn't worry about that if you are Med 20. So in the middle, small intestine is split up into different parts. Don't worry about that, the names of that. Second years, obviously that is an important thing to know, jejunum, ileum, etc. But the main the main thing that takes up the abdominal cavity being the small intestines, with the surrounding colon there as well. And you can see that the colon comes up nice and high, covering the left-hand side of the kidney there, as well as the small intestine covering both the bottom half of the right and left-hand kidney. And you can see how nicely the ureters exit the kidney there, and they come and they basically cradle themselves underneath the exit of the rectum, I guess, and enter into the urinary bladder there. So finally, what Amir mentioned about the accumulation of these structures in the abdominal cavity. So this nutcracker syndrome that we were speaking about, and you can see the aorta, so the main vessel that's taking oxygenated blood away for the. Oh, could you try using your cursor to point out the different structures? I don't. Amir, is there a cursor on this? I don't think there is there?
I don't think so, no.
So we will try for next time, try and find out which one. But I've put in these labels, so if we were able to share these with you, basically all you have to do is tap on the label and it puts a line across so you can see what the structures are. So I will, I'll try and keep those up for just now.
But, yeah, can we just click on the labels as you're talking about the structures?
Yeah. So like we said, the aorta, great big vessel running right down the middle of your body, taking all the oxygenated blood to the structures and the tissues that require it. And the branch that we really are concerned with, that Amir was speaking about, is the superior mesenteric artery. And you can see that nice 42-degree angle there that it creates as it comes down in front of the left renal vein, as well as in front of the duodenum, or the start of the small intestine that we were speaking about as well. And that goes on to supply different structures within the gut as well. But don't worry about that too much. The main point is that this angle here, and what I haven't done is included the fat, so you can see things nice and clearly. But if the fat were in there, you would really get an idea as to how tightly packed this region is. And if things are, pressures change or organs increase in size, things can really have a lot of pressure put on them. So you can imagine if pressure is being put on this superior mesenteric artery, if pressure is being put on that, and you can see that angle is going to decrease, and it's going to be pressing on this left renal vein here, coming towards the left kidney. And the main importance is...
Click on the left renal vein, or just show it more? Sorry.
Yeah, okay. So the left renal vein is this branch here that's coming off of the IVC. So the IVC being the inferior vena cava, the main route of return of deoxygenated blood from the bottom half of the body and structures within the abdominal cavity back up to the right-hand side of the heart. So when blood is taken from the left kidney, it would normally return from the left kidney, as you can see there, and come along this structure back into the IVC and back up to the heart to be oxygenated again. And the main importance about this is that you couldn't see it in Amir's diagram, but this left testicular vein here, so the one highlighted in pink, the importance is that normally when blood is draining from veins, it's coming from distal, so it's coming from further away structures towards the center. So you can imagine that if this vein is providing the left testicle of a male, it's coming all the way up from just above the bladder. It's coming all the way up here. I'll highlight it again just so we know what structure we're talking about. It's coming all the way up and then back in there. But as you can see, if that angle were to be decreased, if that angle were to be decreased, blood wouldn't be able to return from those structures as well, especially the left testicular vein. So when that happens, basically blood can't return as well, so it has to start building up in these vessels. And when it builds up in this left testicular vein, you start to see these varices that Amir was talking about, and they look like worms. So it's these veins that are really popping out because they've got too much blood being held in them because there's an obstruction at some point along the path. And that's really quite a nice piece of anatomy because it shows that angle that we're speaking about, the angle between the aorta and the superior mesenteric artery, is really important, that it's held at 42 degrees. And if that changes, then things can start to go wrong. So I think that's all that I have to say, really. I think that's everything. Yeah. Amir, do you have anything to add?
Just that the so the left testicular vein drains into the left renal vein.
Yeah.
But there's asymmetry here. So the right testicular vein, which is not shown here, drains into the inferior vena cava directly. So you wouldn't have problems with varicosities there. And one more thing, if you have varicosity, it's more common. I mean, it's most common to have varicosities in the left testicular vein. So in the left testicular vein, more likely to have varicosities. If you get it in the right side, it's more suggestive of malignancies or serious pathologies. There are three reasons why, in general, you would get more varicosities in the left testicular vein. One is that in 40% of people, the left testicular vein doesn't have valves. The second one is that SMA, the superior mesenteric artery, that angle that we talked about. And the third one is that it has the left testicular vein has a weird angle of attaching to the left renal vein. So those are the three reasons. And just know that if you get left varicosities, it's more normal than if you get right varicosities, which could point out to malignancies and so on.
Yeah. I know
Perfect.
there's fewer of us here, but do any second years have any questions, particularly with the the duodenum and stuff being involved?
Should I turn off the recording now so we don't?
Yeah,